This is part of our kind of continuing series on updates in traumatic brain injury. No disclosures. Our agenda for the day, we'll be talking about a clinical trial that we'll be bringing to UW-Madison, hopefully April, May or so, depending on contracting and IRB and those sorts of things. We'll be talking about the coming penetrating TBI guidelines, which are due, originally were planned to be released at the end of 2024. Now we're looking like summer of 2025. We'll be talking about updates in subacute chronic subdural hematoma management evidence. This was mentioned by Dr. Trost a few months ago. I thought it would be a good topic to cover. To update you on the coming trial, the Dept TBI-1 trial, the DoD-funded adaptive platform drug trial in acute traumatic brain injury. This will be the first multi-center drug trial in acute traumatic brain injury since the progesterone studies, which were almost 10 years ago. So it's a potentially very big event for brain injury. We're one of about 16 sites. They're planning 672 enrollments. The goal for UW-Madison, really for any of the clinical sites, is to enroll at least one patient per month. So to screen and consent and then enroll at least one. It's kind of an innovative structure of the trial, sort of adapted from the COVID trials. An adaptive platform drug trial where you have, you're starting out with 4 arms, a placebo and 3 interventions. And then depending on the performance of any of the arms, you can then swap in other interventions midway through the trial, or this could potentially go on for years, and continue to use those placebo. And the expectation is that some of these interventions won't work, so they sort of form part of the placebo cohort. In terms of enrollment criteria, it will be 18 to 65, so 65 is a relatively strict cutoff. GCS 9 to 15. They have to be CT positive, so not just concussion. And then after the patients are consented, we'll need to check the GFAP levels, and there's a cutoff of at least 100 and less than 15,000. The patients need to be able to undergo MRI because they'll be getting MRIs at 2 weeks and 6 months. They can't have a contraindication to MRI and can't need sedation for MRI. They need to be able to read, speak, or understand English or Spanish. Some contraindications. That cutoff is kind of coming from other studies of in a GFAP of less than 100, we don't really expect much neurologic or symptomatic consequences. So even if they're CT positive, if the GFAP is that low, they're going to tend to have a benign course. And yes, yes. So yeah, a couple of pixels here, and oh, it may be a little subdural, it may not. It tends to, it may be a calcification along the dura. This is a biomarker evidence of severity. So some exclusion criteria: isolated epidural hematoma, pre-existing conditions, developmental, neurologic, psychiatric, or medical that contribute to significant functional disability. Yes, yeah. So current incarceration, use of any of the investigational products or hypersensitivity, renal dysfunction, hepatic dysfunction, persistent hypotension, inability to swallow the products. So the tablets are going to be kind of horse pills. So if you're thinking that the patient may not pass a swallow, then probably don't want to enroll them. And then low likelihood of follow-up or study compliance. So that would include folks with severe alcohol issues or other functional disabilities at baseline. No, has to be swallowed whole. Yeah. Yeah. Depending on the age, and it has to be administered within 24 hours of injury. So we're ideally screening and consenting them within 12 hours of injury, administering the product within 24. BJ? So we'll actually consent them prior to drawing that. Yes, yeah. So the investigational products are all relatively familiar to us, kind of off-the-shelf products. Atorvastatin, minocycline, which is a tetracycline antibiotic, candesartan, which is an ARB, as well as a placebo. In terms of mechanism, atorvastatin, it's mainly around inflammatory pathways. Minocycline is mainly around matrix metalloproteinases. Candesartan is around the ACE receptors, which we learned from COVID are present in many, many different tissues other than renal tissue, including brain. So in terms of a planned enrollment process, we'd appreciate notifying at this point the study team, which will be myself and possibly Joyce, depending on time, admits likely meeting study criteria. We'll need to consent them for enrollment in order to do the biomarker screening. So there will be some patients that we consent, then we do the biomarker screen, which is a kind of point of care test. They don't pass and don't get randomized or enrolled. If they meet full criteria and are randomized, we need to start treatment within 24 hours of injury. They'll need to take the first medication in the hospital, but then they can go home with a drug pack. 2 weeks. So. All right, so did anyone have any questions about the trial?
With some of the consent process.
Yes. Yes, and because we only need to enroll one patient a month, we don't have to necessarily.
Don't say it like that. That's very hard to do. Yeah.
But
that is a hard goal based on what you've just described. Yeah. So just make sure you have, because the residents during the days, weekdays are going to be busy. Maybe you could also engage AP. Another idea, because recruitment is really hard.
Yes, one issue is going to be transfers that we get from very far away, because they need to come back several times, including in the first 2 weeks. And so if they're coming from 4 hours away, they may not be a great candidate for the trial. Definitely local people with the idea.
And they follow for at least 6 months.
Yes.
Just a quick question on if a lot of these patients do spend, say, 1 to 2 weeks, would an inpatient 2-week MRI still satisfy that condition, or do they need to be discharged and then come back?
So this gets very complicated, but The MRI that is designated for the trial has to be tested periodically and sort of synced with different phantoms. And right now, the plan is to use the Wimmer MRI for
Okay.
that, which is an outpatient MRI.
I see.
So, but in these GCS 13, 14, 15, hopefully at 2 weeks,
Yeah.
they are discharged. But
For the MRI stuff, if there are any studies that the neuroradiologist might find sub-study, and that would be a nice way to use some of that MRI data for something else.
yes, yes,
Because they just usually have like another series of images and that's it.
yes.
Just one other quick question about the exclusion criteria. I know you mentioned psychiatric disorders. Is that including like all like depression, anxiety, simple like mood disorder stuff that's
Causing functional disability.
Okay,
So
good.
employed,
functional people who are doing fine with their depression can still be enrolled? Okay.
yeah.
I just wanted to make sure. I felt like that would exclude a lot of our patients.
All the residents.
Yeah.
Yeah.
It's just such a common.
Sports fans.
Yeah, exactly.
Okay. The Irish.
So now we'll move on to penetrating TBI. We'll start with the case. And I'm going to do it in 2 different scenarios because I think it's interesting. 21-year-old male brought in by ambulance after an assault. Since initial exams, eyes closed. He falls in the right upper extremity. Starts vomiting, then unresponsive, intubated. His blood pressure is systolic 90/50, heart rate 110. This is his initial imaging.
Was he assaulted? Looks like a Colt 45.
Yeah. Anyone want to talk about what? Oops. Anyone?
Tell us about this game. Just read the shit.
So let's see.
When you're trying to stall for time to say it's a CT scan, you probably knows that. While you think you are, you take that.
Yeah, so you see this is a CT scan. There's clearly a break in the bone at like the right frontal region, and there's fragments intracranially, as well as some hyperdense material, like blood or edema in that area.
The fragments of it, you form are the 2 characteristics. Fragments, both intracranial and extra. Look at the extracranial fragments.
Like bone or
So
something.
they attenuate very differently.
Yeah, they look
Okay.
different. Yeah.
Okay, so it's 2 different materials. Then we want to know about the fragment. Is it compressed? If I look, is it pushed front to back or side to side? And that's it.
Okay. So I was going to do this as a survey, but fortunately the Slido. So initial management for scenario one, fluids, blood for systolic greater than 100, avoid menthol only. ER washout and wound closure with DVD. OR wound exposure, exploration, limited parenchymal debridement, EBD. OR wound exploration, deep parenchymal debridement, EBD. OR wound exploration, limited parenchymal debridement, large decompressive craniectomy, drains, EBD.
Is this one of those like next best step, or is it?
Yes. Or what would you think is appropriate in this case? Anyone want to volunteer? We could raise hands. How about the first one? Any vote? The second one?
I mean, I think he needs fluids because he's hypotensive and his heart rate, he's tachycardic as well. So I'm concerned that he could have some type of, he could be developing some type of shock, or he at least could be developing, manifesting some underlying hemodynamic instability. But then, yeah, so I think he does need that.
Okay.
That's not the end all be all for him, for sure.
Anyone vote for EVD only? ER washout and wound closure with EVD. Or wound exploration limited parenchymal debridement, EVD. Or wound exploration deep parenchymal debridement, EVD.
Third last.
The last one.
What would be reasons to?
He's hypotensive.
Oh, right.
Yeah, you're gonna drop his pressure. We'll do a second scenario. Same gentleman brought in by ambulance after assault and intubated on the scene. His initial exam is GCS3T. He doesn't have pupils or corneals. He does have a cough and gag. There's brain material at the entry site. His systolic blood pressure is 90/50. His heart rate is under 10. Same imaging. Any change in management based on that exam?
Did it have brainstem? Sorry, I don't know.
Cough, gag.
Cough, but no pupils, no.
Paralyzed for intubation or?
He has a training.
Is this pupils like small or are they large?
So one of them has a hematoma in it, and the other one is small.
Okay.
Any change in management? We're still going with OR wound exploration, deep limited parenchymal debridement, large decompressive craniectomy, and EVD.
I mean, I think I would still be aggressive in that he's young, he could have seized. We don't know at this point why his exam is so poor. The exam, his scan itself doesn't support necessarily that exam. So I would want to be aggressive early to address the reversible things and then see if there's other metabolic derangements, other seizures we can address. That would be clouding things initially. I don't think it's appropriate to just say good luck, goodbye.
And two other things for the imaging there's a CTA, right, that we had?
Yes.
There was contrast. So we would be able to look at the neurovascular structures just to see this sort of.
He did certainly have intracranial flow.
Yes.
Okay, sounds good. No posterior circulation, large vessel occlusions, and then he had no major uncle herniation or Duray hemorrhages on the lower conspecific. So, yeah, I would do the same thing.
So the 2025 guidelines for the management of penetrating TBI, it's pending. The first new guidelines, actually, this is a typo, since 2001, so this is almost 25 years. The process started in 2022. It utilized a traditional evidence-based and Delphi process, so kind of expert consensus. And then there was no distinction between military and civilian evidence sources. What was kind of driving this was a TQIP versus DOD comparison, where what was seen was that in the military penetrating TBI population, there was much, much higher survival rates than in the civilian side. And this was because they were getting completely different treatments. That on the military side, they were getting craniotomy, craniectomy, ICP monitoring. Their mortality was 23%. And then meanwhile, on the civilian side, they weren't getting surgery and they were dying at much higher rates. And interestingly enough, the median time to death in the civilian side was 2 days. That essentially they gather the families, have discussion, and draw on the second day. And
I had a question. What was the age groups between these two patients? Because I assume like military, it's mostly men, young men. And
same thing on the civilian side.
yeah, I mean, yeah, I know, but I just wanted to clarify. I don't know.
They're in a different military.
Yeah.
There's no pension.
No pension.
We're a huge scare. I mean, everybody in the U.S. military is trying to take care of their colleague and get them into the streets.
Some of the recommendations that have come out of this: aggressive care and avoidance of needleism are central to achieving the best possible outcomes and penetrating TBI. So the 2001 guidelines gave you all sorts of excuses not to operate. This is giving you all sorts of excuses to operate and be aggressive with these. And then current predictive models shouldn't be used to guide initial treatment decisions because they hadn't been validated, don't seem to have a lot of discriminatory power. So in terms of initial surgery versus operation, they recommend performing craniectomy or craniotomy early to reduce the likelihood of death or poor outcome. They say within 5 hours, really we should be trying to get these folks to the operating room as quickly as possible. On the blunt side, there's still some disagreement in diffuse injuries, whether craniectomy is of value, at least in the penetrating side. It seems as if craniectomy is really the definitive treatment. And even in diffuse injuries, taking these folks for craniectomy early improves outcomes. In terms of conservative debridement versus radical debridement, so in this case, this person had a gunshot, a projectile right near the brainstem. Doing a limited debridement of this bone that was immediately accessible is reasonable, but trying to do a deeper debridement to get all of the bullet fragments is not appropriate. Of course, we should repair CSF leaks and fistulae, and to reduce the risk of infection. They suggest tensor fasciolata, pericranium or temporalis fascia or allograft, and to only use it CSF and drainage and lumbar drainage as an adjunctive measure. One thing that some folks have been doing for a while is attempting to culture these patients intraoperatively, so get intraoperative cultures and guide antibiotics on that basis. It doesn't seem as if the cultures that you get intraoperatively on these patients really reflects what they'll ultimately get infected with. So intraoperative cultures probably don't need to be done. However, if there is gross purulence or evidence of infection at the original surgery, you could do that. They didn't find great evidence for timing cranioplasty, but the consensus was to do cranioplasty as soon as medically and surgically feasible. Antibiotic prophylaxis, they didn't find a strong recommendation on the routine use of prophylactic antibiotics. However, in cases such as bullet tracks through the frontal sinus or other air sinuses, they thought it was appropriate. And certainly they thought it was reasonable to do antibiotic prophylaxis, but didn't think that it was essential. They provided a toolkit, and this is becoming more of a concept in all acute care neurosurgery, a futility assessment toolkit. So instead of saying this patient has a poor prognosis, we don't need to do anything, what they advocate for is pursuing to essentially to futility. And, and this in many ways resembles the criteria of the brain death, that normothermia, normalization of physiology, removal of pharmaceutical effects of sedation and paralysis, then a very detailed clinical exam, including finding no brainstem reflexes or massive transcalaveral herniation. Then they bring up some CT features that would support a finding of futility, such as destructive trajectory through the brainstem or through the hypothalamus. This doesn't include that in the previous guidelines they suggested a track through the ventricle was inevitably fatal, and that doesn't seem to be the case. And then, of course, if they have concomitant injuries, advanced age or coagulopathy or a terminal medical illness, that would also aid in the judgment of futility. So in this case, this was a patient of Dr. Day's. He got a right decompressive hemicraniectomy with acute subdural hematoma evacuation. Got an ICP monitor, closure of his traumatic skin wound. At discharge, he was alert and oriented ×3, followed ×4. He seemed to be a little weak on the left side. At last check, I saw him sending my chart messages. So these patients will really surprise you. And making a judgment really early in these can often foreclose sometimes very, very positive outcomes in patients.
Especially young people.
Yes. So we're going to move on to our last topic, which is the management of subacute and chronic subdurals. Second case, an 81-year-old female presented after a chair to floor syncopal fall. She had been experiencing several months of feeling a bit off and some word finding difficulties, but otherwise didn't have any neurologic complaints. Do the AL ×4, no pronator drift. She did have a past medical history of heart failure with preserved ejection fraction, type 2 diabetes, stage 3 chronic kidney disease. Creatinine was 1.31. BUN was stable at 23. This is her imaging. Everyone want to talk about what they see? Okay.
So axial head CTs, there's right sided chronic appearing subdural with some acute components. There's some midline shift.
There's compression of it. Are there septations or membranes?
Yes, there's
Yeah, I should measure 5 millimeters in the bunch of.
might say something about quality of the brain.
It's atrophic, appropriate for anyone.
So much.
Atrophy.
And we'll have to do a show of hands again. Case 2 management, would you put her on steroids, take her off aspirin, craniostomy change? Anyone vote for that? Burr holes washout with postoperative drain. Anyone vote for that? Mini craniotomy with postoperative drain. Anyone vote for that? Okay.
I think that I think that's the reasonable circle. I would also agree with them embolization too, either before or afterwards, mainly because with those septations and presumed memory, I don't know, it's likely to be able to get an adequate deep evaluation of craniostomy or burr.
Middle meningeal artery embolization alone. Anyone vote for that? Craniostomy drains with middle meningeal artery embolization. Anyone vote for that? Burr holes washout with postoperative drain and MMA. Anyone vote for that? Mini craniotomy with postoperative drain and MMA. So kind of a little bit mixed. For a lot of these, for me, I do a tristil craniostomy for subdural drain, and the incision is at the superior temporal line, a bit longer than what you do for a EVD, essentially lateral to Coker's point. This is the starting trajectory of the drill for that, and then start drilling, and then start to take the top of the drill forward to go more oblique to the skull to get your craniostomy. This is the trajectory of this, the drain once it's placed. So you're trying to go along the track of the blood posteriorly. You can then have the patient supine, flat, with the drainage bag, the Becker drainage bag down on the floor to create a slight negative pressure gradient. Another twist drill craniostomy technique that people do is the SEPS drain. I don't think we stock that here. It's a larger bore craniostomy, and you screw it into the skull, and then it's attached to a JP to create a slight negative pressure. So some historical theories on chronic subdural hematoma involving expansion. Everyone seems to agree that the initial precipitating event is a rupture of the bridging veins. One idea that became very popular, and I saw it in the CT report a few weeks ago, is that this was driven by osmotic expansion, that fluid would move in from the surrounding tissue into these from osmotic expansion. Another factor that seemed to be evident is that there was capillary leakage. Prior to 2017, there was quite a few different, including RCTs, on chronic subdural hematoma management. These were collected in systematic reviews. Reading these reviews, they would go to very, very detailed points, such as whether or not you should use warmed or cold irrigation when doing a burr hole evacuation, or should you place a subperiosteal versus subdural drain in these patients after burr holes. The common conclusions in these systematic reviews was that closed system drainage after burr-hole evacuation reduced the rate of recurrences. Treatment with choice drills is equivalent to burr holes. As of 2017 or so, treatment with craniostomy seemed to produce similar outcomes to burr holes. After burr hole craniostomy, the postoperative bed header in the elevated position instead of the supine position might reduce the length of hospital stay. This is the level of detail that's in this review got. And then with a choice drill to do it 48 hours instead of 96. There was a recent randomized control trial in 2022 comparing burr hole mini craniotomy. They enrolled 245 patients. They did find slightly better outcomes for burr hole compared to mini craniotomy or twist drill, but it didn't reach statistical significance, which they suggested might be to do with being underpowered. More contemporary understanding of chronic subdural is that, again, starting with these bridging veins, but that the MMA branches penetrate the dura, creating a capillary network called the interdural plexus. And there was increased understanding of these dural border cells, and that after injury, inflammatory cells migrate to this layer. It then creates this very complex capillary filled membrane on the skull surface of the hematoma, which then leaks into the cavity lined by a membrane. And this is another diagram of this. That you have this very complex capillary network that forms, and this is some staining that was done to demonstrate this of this very complex capillary network. One thing that has become more evident in recent years is that cognitive impairment in these patients is very common. So before and after treatment, for chronic subdural, 60% of patients will have before treatment cognitive impairment. So even though they don't have pronator drift, even though they're living at home, it's not uncommon that these patients will be severely affected by their chronic subdural. And then in studies that did look at cognitive impairment, there was a pretty significant drop in the level of cognitive impairment in these patients after treatment. Middle meningeal artery embolization was first described 20 years ago or so. More recently popularized in the last 5 to 10 years. Here are some angiograms, including superselective catheterization of the middle meningeal artery. This is onyx embolization, including the artifact after onyx embolization. An influential study in chronic subdurals was a study that came out in 2020 from Peter Kahn, covering 154 cases. This was MMA only. Another study in 2017 out of Korea indicated that they had a recurrence rate in chronic subdurals of less than, I think it was 1.5%. So as compared to the 20% that was being reported elsewhere in the literature, this seemed like a magical procedure. There are a number of trials in chronic subdural being done right now. This is a listing of 9 different trials. The agents that they use are varied between trials. Typically, the trial requires a specific agent. This one is kind of membrane is kind of unique that they allow a number of different embolic agents, and as well as chemprotectant and SWEMA. In November, there were 3 publications in the New England Journal on the results of these treatments. This was the SQUID trial. This was using onyx, and this was also using onyx and Magic MT. In terms of outcomes, Embolize, which is the Onyx trials sponsored by Medtronic, did show a reduced reoperation rate at 90 days. Didn't have a safety outcome. STEM with squid also showed a reduced rate of recurrence, reoperation, major stroke, MI, or death at 180 days. Again, well, in this trial, there was a significant increase in mortality in the MMA embolization group. And then the Chinese trial, Magic MT with Onyx, did not meet its outcome. It had a significance of 0.10, so there was a trend towards better outcomes in MMA compared to standard treatment, but it didn't meet the pre-specified criteria. One thing that I would really highlight from the successful trials, though, is the number needed to treat. So in Embolize, it was 14. In STEM, it was 6. So that's not very typical for a surgical procedure to have a number needed to treat of 6 or 14. And so I don't think that overall these outcomes were quite what people expected. It's always nice to have positive results from trial, but it wasn't quite as dramatic as had been expected. Some open questions in chronic subdural density factors, including what is the treatment and for subdural hygromas? Is there a role for MMA in subdural hygromas? Embolic material choice, is there an indication for standalone MMA? MMA embo as rescue. Should we be doing this in bilateral chronic subdurals? Should we do this before surgery or after surgery? Is there long-term functional benefit to the cost? I think, at least based on the November results, that it's not quite as definitive as it appeared even 6 months or 12 months ago. Any questions?
So, yeah, how would you handle those chronic subdurals now, patients, based on the results of those trials?
So one thing that I thought was, again, it was a case series, but people seem to report that in these patients with mixed density subdurals, like that patient, that seems to have increased risk for recurrence after twist drill or burr hole, that they do equally well with MMA. So I think that if I get a patient with an uncomplicated, non-septated, hypodense subdural, I'll probably just do a twist drill. But in a patient like this one, where it's acute on chronic, mixed density, septated, then I would think about following it with MMA. Another very open question is asymptomatic patients, and given that we see a much worse cognitive baseline in patients with a chronic subdural, should we, in asymptomatic patients, do MMA as an opening to potentially address it and spare them any further procedures? But I would also stay tuned that there's 6 other trials due to report in this, and certainly the evidence could shift.
What's the usual timeline for resolution of these subdurals after the embolization? Because if we have an acutely symptomatic patient, I imagine you need to do potentially both drain and then embolize.
People say anywhere from 30 to 90 days. So it's definitely not that the next day it's gone. It's usually that at 30 days there's a 60% reduction in volume, and then at 90 days it might be gone. Thanks so much.
Thank you.